Hello, dear students and friends. In my lecture series in obstetrics and gynecology, the next topic which I have chosen is of clinical relevance, especially in this era of corona pandemic. It is pregnancy and labor in COVID-19 infection, the fact file. We all know that it is a novel virus, and guidance which is being given by various organizations and by societies is constantly changing. But the basic facts still remain the same and would be of immense use to us in our clinical practice. The data which I have included in my presentation is from present guidance as per October 2020. So I hope it would be useful for all of you. Pregnancy and labor in COVID-19 infection, the fact file. COVID-19 is caused by a virus known as severe acute respiratory syndrome coronavirus 2 and is a global public health emergency. Coronaviruses are enveloped non-segmented positive sense RNA viruses belonging to the family Coronaviridae. In the past decade, two epidemics have been caused by these beta coronaviruses, that is SARS-CoV and MERS-CoV. SARS-CoV is severe acute respiratory syndrome by coronavirus 1, and MERS is Middle East respiratory syndrome by a coronavirus. They have caused more than 10,000 cumulative cases in last 2 decades, and mortality rates also were in the range 10 and 37%. It may be noted that COVID-19 belongs to the same coronavirus subgroup and shares genome similarly in about 80 and 50% similarity with these two viruses respectively. Most global cases have an evidence of human to human transmission. Viruses can be readily isolated from respiratory droplets, secretions, feces, and fomites. Transmission is known to occur most often through close contact with an infected person within 2 meters and contaminated surfaces. Though guidance is again changing, and it is now said that surfaces do not transmit this infection, but we don't know. It is to be noted that SARS-CoV-2 virus has been found to be viable in plastic and stainless steel surfaces up to 72 hours and copper and cardboard up to 24 hours. So this was the mode of transmission. As I had said previously, information is evolving rapidly. Interim guidance by multiple organizations is constantly being updated and expanded. You would see that my slides are too crowded, but it is only because I've taken my content from various guidelines, and so that it could be a ready reckoner if you read through it. Prevention is always better than cure, and this applies for pregnant women as well. Pregnant women should follow the same recommendations as for non pregnant for avoiding exposure. The five important points are: stay home as far as possible, physical distancing, hand hygiene, disinfecting surfaces, and wearing a 3-layer face cover in public. Those who come in contact with a confirmed or suspected case should be thoroughly monitored. Now, as far as pregnant workers are concerned, if they are in occupations other than healthcare, they may continue their work until they deliver. And it must be kept in mind that all the precautions have to be taken at workplace as well. Risk mitigation, risk that is reassignment at terms to roles with reduced risk of exposure or self quarantine can be considered, and it would help to reduce the individual's risk of being infected postpartum and peripartum. When maternal infection has broader implications, like when it affects healthcare workers or if there is infant exposure, These various facts are to be kept in mind. The patient's comorbidities and individual work situation should guide a clinician's response to requests for medical leave. Now, course in pregnancy. We know that pregnancy is a physiological state and as such it predisposes women to respiratory infection. The physiological changes which occur in pregnancy occur in the immune and cardiopulmonary system and they make the pregnant women more likely to develop severe illness after infection with respiratory viruses. Now, if we see it in relation to SARS-CoV infection, pregnancy and childbirth generally do not increase the risk of acquiring this infection, but at times may worsen the clinical course if you compare it to non pregnant individuals of the same age. It has been seen that more than 90% infected mothers recovered without undergoing delivery. Clinical course of severe and critical COVID-19 infection in hospitalized pregnant women has been seen to be shorter than if you compare it with hospitalized non pregnant patients. Some patients with severe COVID 19 have lab evidence of exuberant inflammatory response, what we call as the cytokine release syndrome, and this was associated with critical and fatal illnesses. Whether the normal immunological changes of pregnancy affect the occurrence and course of response is unknown. Now, for us to have a level 1 evidence, we need a meta analysis of various systematic reviews. There is not much literature on COVID 19 and pregnancy as such, but here I would like to show you a systematic review which included 11,000 pregnant women who were suspected or confirmed cases of COVID 19. The maternal outcomes, if you look at, 49% had pneumonia, 30% received oxygen via cannula, 13% had severe disease, 4% were admitted to an ICU, 3% received invasive ventilation, and 0.8% received advanced ventilation, extracorporeal membrane oxygenation, and 0.6% died. So these were the maternal outcomes of pregnant women. Now, the symptoms. There is a galaxy of symptoms which can occur, and it is not necessary for a person to have a peculiar symptom to be identified as COVID 19. There could be any of these symptoms in the list: fever, cough, dyspnea, anosmia, ageusia, that is, loss of taste or taste abnormalities, sore throat, myalgia, chills and rigors, headache, rhinorrhea, and/or nasal congestion, nausea, vomiting, diarrhea, fatigue, confusion, chest pain, or pressure. So it could be any of these symptoms. Now, if you look at the data from that systematic review on 11,000 pregnant women, 40% had fever, 39% had cough, 19% had dyspnea, 15% loss of taste, 10% myalgia, 7% diarrhea. The less common symptoms which were seen in these pregnant women were sore throat, rhinorrhea, or nasal congestion, nausea, vomiting, and loss of smell. Women who were universally screened for COVID 19 during pregnancy, in them 7% only tested positive, and 3/4 of these women were asymptomatic. So it mainly remains in an asymptomatic phase. 18% of the symptomatic women tested positive. It is important to note here that clinical manifestations may overlap with normal pregnancy symptoms or certain symptoms which arise in pregnancy with complications, like fatigue, shortness of breath, nasal congestion, nausea, vomiting. These are common symptoms of normal pregnancy. Then other symptoms of preeclampsia or eclampsia like headaches, dizziness, weakness, all these are also present in COVID 19. Complications of infection could be acute respiratory distress syndrome, myocardial injury, and COVID 19 can involve other organ systems also. Pregnant women were more likely to need ICU admissions versus non pregnant one, and it was identified that they had certain risk factors. like severe disease, age more than 35 years, obesity, hypertension, and pre existing diabetes. Now, whenever there is any viral infection, we are always concerned about its transmission to the baby. Possible vertical transmission has been reported in several cases of peripartum maternal infection, that too in the third trimester. Congenital infection is possible, but it is uncommon, less than 3 to 4%. Most neonatal infections were due to respiratory droplets when neonates were exposed after delivery to mothers or caregivers who had this infection. In the absence of concurrent issues like early preterm birth or abruption, neonatal outcomes have been uniformly good. Mostly, the neonates were asymptomatic or had mild disease and did not require any respiratory support. Fetal sequelae of maternal infection in the first and second trimester, however, are sparse and there's less literature on it. Now let us look at the lab features. The typical sepsis profile, which is more diagnostic of COVID-19, includes D-dimer, CRP, LDH, troponin, ferritin, and CPK. If the levels of more than 1000 nanogram per ml of D-dimer, then it is diagnostic. A CRP more than 100 milligram per liter, LDH more than 245 units per liter, troponin more than 2 times the upper limit of normal range, ferritin more than 500 micrograms per liter, and CPK again more than 2 times the upper limit of normal range. There is a decrease in absolute lymphocyte count, and it is found to be less than 800 per microliters. In the systematic review on 11,000 pregnant women, it was seen that most of them had lymphopenia, 35%, leukocytosis was present in 27%, elevated procalcitonin level in 21%, abnormal liver chemistries in 11%, and thrombocytopenia in 8%. Now coming to the classification, how would you classify the disease as mild, moderate, severe? This classification was according to National Institute of Health, and it was given for non-pregnant women, asymptomatic or pre-symptomatic infection in which there is a positive test but no symptoms as such. Then symptomatic can be divided into mild, moderate, severe, and critical illness. Mild illness, if a symptom of fever, cough, sore throat, malaise, headache, or muscle pain is there, but there is no shortness of breath, no dyspnea, or no abnormal chest imaging. In moderate illness, there is evidence of lower respiratory tract disease, which is seen by clinical assessment and by imaging, and an oxygen saturation of more than 93% on room air at sea level. In severe illness, this oxygen saturation decreases. It is equal to or less than 93%. Respiratory frequency is more than 30 breaths per minute, and the ratio of arterial pressure of oxygen PaO2 and FiO2 is less than 300, and on imaging, lung infiltrates are more than 50%. In critical illness, in addition to all these, there could be respiratory failure, septic shock, or multiple organ dysfunction. There's another classification, the WHO classification. It remains the same. However, the disease is divided into mild, severe, and critical. Approach to diagnosis. Whenever a woman comes with fever, cough, dyspnea, myalgia, diarrhea, loss of sense of smell or taste, it could be considered a possibility. Patients who have severe lower respiratory tract illness without any clear cause, or those residing in or travel to location where there is community transmission of SARS-CoV are suspects. A close contact with a confirmed or suspected case of COVID-19 in the past 14 days should heighten suspicion, and all these women who have these symptoms should be investigated. How to test? Patients who meet the testing criteria should undergo an RT-PCR for SARS-CoV-2 RNA testing on nasopharyngeal swab specimen, ideally. In addition, testing for other respiratory pathogens which could be the cause of their symptoms, like influenza, respiratory syncytial virus, etc. In areas where infection is prevalent, testing all patients on presentation to labor and delivery or a day before their scheduled admission to the labor ward with a rapid test for SARS-CoV-2 is reasonable. A positive RT-PCR generally confirms the diagnosis, but in pregnancy, occasionally false positives have also been seen to occur. False negative tests on initial testing also appear common in pregnancy, and they have been seen in 4 days preceding symptoms or on the first day of symptoms. Now, sensitivity of a test depends on various other factors also. The specific RT-PCR assay which we are doing, the type of specimen which we are taking, like nasopharyngeal specimens, have higher sensitivity than oropharyngeal or nasal specimens, the quality of specimen, and the duration of illness at the time of testing. If the initial nasopharyngeal test is negative, but there is a suspicion, and determining the presence of infection is important for management and for infection control, then the test should be repeated in 24 hours to a few days. Infection control precautions, however, should continue till repeat evaluation is done. Two subsequent negative samples generally rule out infection. If still there is a high suspicion and diagnosis is required for management, lower respiratory tract specimens, sputum, bronchoalveolar lavage, they should be taken and can be tested because they have a higher sensitivity. Now, in pregnancy, whenever we think of chest radiography, we always want to be sure that there should be no fetal affection. A probable chest radiograph is sufficient for initial evaluation of patients with complications and extent of lung involvement in hospitalized patients. However, a single chest radiograph carries very low fetal dose radiation in the range of 0.0005 to zero point 0.1 milligram. A CT should be performed if indicated. Fetal radiation dose for a routine chest CT is also low and not associated with an increased risk of fetal anomalies or pregnancy loss. A lung ultrasound can also be done. It can be done at the same time as an obstetric scan for a quick diagnosis of pneumonia in a symptomatic pregnant woman. Chest imaging, especially CT scan, is essential for evaluation of clinical condition of a pregnant woman and to decide the treatment. Fetal growth restriction, microcephaly, and intellectual disability are the most common adverse effects, but they occur from very high dose radiation exposure, like more than 610 milligrays. Now, as you can see from this table, a chest radiograph, two views, has very low radiation dosage to the fetus. Similarly, a chest CT or a CT pulmonary angiography have 0.01 to 0.66 milligray radiation dose. Symptoms of COVID-19 are similar to multiple other viral and bacterial infections like influenza, adenovirus, hemophilus influenzae, mycoplasma, pneumonia. The test for influenza when testing for SARS-CoV is at times essential because co-infection is common. Co-infection is also common with tuberculosis. Now, coming to pregnant women, some COVID-19 related lab abnormalities are the same as seen in severe preeclampsia and HELP syndrome, like hemolysis, elevated liver enzymes, and low platelets. Prolonged prothrombin time, elevated D-dimer, procalcitonin, and C-reactive protein levels, and low fibrinogen levels are seen in COVID-19 infection. The reference ranges, however, for D-dimer, CRP, and fibrinogen are a bit high in pregnancy. Some neurological manifestations of COVID-19, like headache, acute cerebrovascular disease, and seizures, are common. They can be seen in pregnancy, a normal pregnancy with severe preeclampsia or eclampsia, and without infection. Acute kidney injury is also one of the complications of COVID-19, and that could also be seen in pregnancy with severe preeclampsia, abruptio, or shock. However, in order to differentiate, uterine indices more than 90 percentile of gestational age, and the ratio of SFLT1 and PIGF more than or equal to 85 at less than 34 weeks, or more than or equal to 110 at more than 34 weeks of gestation support the diagnosis of preeclampsia. In a small observational report, these markers were normal in 5 out of 6 women who had symptoms of preeclampsia. They had elevated lab tests, and so the suspicion went in favor of COVID-19, but resolved on improvement of infection. Prenatal tests and prenatal care. There are many points which are important in the antenatal care. First is preventing exposure in the community. Patients with potential exposure you need to identify, and routine prenatal care in uninfected women should go on as per the algorithm given by FUGO. However, in this COVID era, we must find ways to reduce the time spent for consultation in office for patients with high-risk pregnancies. A 75-gram 2-hour oral GTT can be done instead of an OGCT and 100-gram 3-hour GTT in those women who have positive results on blood sugar reports. Cell-free fetal DNA screening can be used at more than 10 weeks for screening Down syndrome rather than the combined tests, which includes an MT scan and serum biomarkers. Now, we do not want these women to come to the clinics unnecessarily. So, telehealth capabilities and means of measuring blood pressure at home should be motivated. Psychological impact should also be recognized and support offered because these women may have severe depression and anxiety. This was the algorithm I was talking about, antenatal outpatient care. Now, here, as per telephonic talk, you can decide whether the woman belongs to high risk group or low risk group, and on the basis of her symptomatology, you can find out whether there are chances of her having the infection. If she does not have infection, then routine visits can be cut down and visits, telephonic consultation in these visits can be allowed unless and until she is required to come for various investigations. But if she is a suspect case of COVID-19 infection, then various precautions have to be taken by the team who is examining this patient, and then you have to investigate the woman and then subsequent triage whether she requires emergency treatment or not, or whether she can come for follow-up is to be decided. This is the suggested modified antenatal care schedule for low-risk pregnancies. And as you can see in this chart, the number of times she needs to come in person have been reduced. And at other times, there could be a phone or a video conferencing call. She needs to come in only when specific investigations are required. So this can be followed by all, especially in this COVID era. Now, the medical management of these women who are infected with COVID-19 and are pregnant. Based on illness severity, home care, mostly 86% known or suspected COVID-19 have mild disease, they have no shortness of breath, and they do not warrant hospital level care, except for obstetric problems like preterm labor or for concern for rapid deterioration, inability to promptly return to the hospital, or inability to self isolate. They should be followed closely for progression to severe or critical stages. Patient instructions and care in the antenatal period are similar to those who are not pregnant. In the third trimester, perform a fetal kick count and report decreased fetal movements. A follow-up visit at least once in 2 weeks of diagnosis is essential. For worsening of symptoms, The red flags have to be identified and they should be told to report if worsening shortness of breath occurs, there's apnea, unremitting fever greater than 39 degrees despite appropriate use of acetaminophen, inability to tolerate oral fluids or medications, persistent pleuritic chest pain, or new onset of confusion or lethargy or cyanosis. So, in my cases, they can receive home treatment, antenatal care remains the same, and care for COVID infection also remains the same as a non pregnant. Now, hospitalized based care. Indications for hospitalization mild disease, but additional comorbidities like poorly controlled hypertension, diabetes, or a pregestational diabetic, chronic kidney disease, chronic cardiopulmonary disease, or immunosuppressive states. Then, moderate to critical disease and severe disease in which there is oxygen requirement and comorbidities. At hospital, a multi-specialty team should take care of these women. It should be at a level 3 or 4 hospital with obstetric services and an adult intensive care unit. COVID-19 status alone is not necessarily a reason to transfer a non critically ill pregnant woman. So, such women can be managed at that same place where they were receiving treatment but in an isolated unit. Fetal monitoring. Frequency of fetal testing depend on the gestational age, stability of maternal vital signs and oxygenation, and maternal comorbidities. Discussion with the patient and family about the increased risk of stillbirth perinatal morbidities should be done. For hospitalized patient, you can have a Bluetooth enabled external fetal monitor which can transmit the fetal heart rate tracing to the obstetric provider so that you do not have to go in person and check the fetal heart rate. A continuous monitor should be put on patients who are unstable, hospitalized, and in whom emergency cesarean section would be performed for persistent, non reassuring fetal heart rate pattern. An abnormal tracing might also help guide maternal oxygen therapy. In patients with stable oxygen saturation and who are hospitalized, an NST non stress test can be done once or twice daily in order to identify the fetal status. Maternal respiratory support. A critically ill, profound, acute hypoxic respiratory failure may be a dominant finding. General supportive care similar to that in patients with ARDS is required. Various complications of COVID-19 related ARDS include acute kidney injury, elevated liver enzymes, even cardiac injury. There could be cardiomyopathy, pericarditis, pericardial effusion, arrhythmia, and sudden cardiac death. During pregnancy, maternal peripheral oxygen saturation should be maintained at more than or equal to 95%, which is in excess of oxygen delivery needs of the mother. If SpO2 falls below 95% and arterial blood gas to measure the partial pressure of oxygen, that is PaO2 is required, maternal PaO2 greater than 70 mm per mercury is desirable to maintain a favorable oxygen diffusion gradient from the maternal to fetal side of the placenta. WHO recommends maintaining maternal SpO2 between 92 to 95% once the patient is stable. In the ICU, severely ill patients are often managed in prone position. Left lateral position is an alternative but may not be as effective. Even a semi prone position can be difficult in the last half of pregnancy. It is said that with prone position, the lower parts of the lung also receive oxygenation and so respiratory distress is less. Padding above and below the gravid uterus if the uterus is more than 24 weeks is desirable to offload the uterus and avoid aortocable compression. Permissive hypercapnia, that is PCO2 less than 60, and extracorporeal membrane oxygenation, if indicated for management of acute respiratory distress syndrome, do not appear to be harmful to the fetus, but however, data are limited. High positive and expiratory pressure strategies Maintaining it more than 10 millimeters of mercury, if considered, require close ongoing maternal and fetal monitoring because they decrease the preload and cardiac output. Now we know that COVID-19 infection causes thrombosis and clotting disorders. So, what is the role of venous thromboembolism prophylaxis? Direct data is limited but suggests an increased risk. Three cases of thromboembolism in 637 hospitalized infected pregnant women were seen in a systematic review. Pregnancy, reduced mobility, and dehydration itself amount to the risk. Routine pharmacology VT prophylaxis is recommended in hospitalized patients unless there is a contraindication like bleeding, severe thrombocytopenia. For antepartum prophylaxis in women who are not severely or critically ill and who may deliver within a few days, unfractionated heparin 5,000 units subcutaneously 12 hourly should be started. Low molecular weight heparin, that is enoxaparin 40 milligram daily, may be considered in women who are unlikely to deliver within the several few days and in postpartum. Use of dexamethasone. Steroids are the mainstay of treatment for COVID infection. Dexamethasone, 6 milligram per day for 10 days or until discharge, is recommended for severely ill non pregnant women who are on supplemental oxygen or ventilatory support. Glucocorticoids used for management of refractory shock in critically ill patients. They are generally used. If antenatal steroids for fetal maturity, the usual doses of dexamethasone, 4 doses, 6 milligram intravenously, 12 hourly to induce fetal maturation and continue maternal treatment to complete the course of dexamethasone, 6 milligram orally or intravenously daily for 10 days or until discharge, whichever is shorter. So, if you want to give steroids to enhance lung maturity, dexamethasone can be given in the usual dose, but however, it has to be continued till discharge. Other glucocorticoids like methylprednisolone or hydrocortisone to complete the course of maternal treatment may be used because they result in less fetal steroid exposure. Now, for fever and pain, we do need NSAIDs and acetaminophen. The anecdotal reports of possible negative effects of these two drugs on COVID-19 patients have been seen. Acetaminophen, however, is preferred antipyretic and analgesic agent and can be given if possible. Abnormal liver chemistry secondary to COVID-19 has been seen with the use of this drug, and there is a concern of hepatotoxicity. However, doses less than 2 grams per day are safe in absence of severe or decompensated hepatic disease. If NSAIDs are needed and the patient has not delivered, the lowest effective dose guided by the gestational age related potential toxicity to the fetus should be given. ACOG, WHO, and European medicines agencies recommend not avoiding NSAIDs in COVID-19 patients, especially when clinically indicated. It means that they need to be given. Now let us look at the safety of other medications which are commonly being used for COVID-19 infection. Antiviral remdesivir. For pregnant women who would otherwise qualify for this injection and it is available, it is recommended. It has been used without reported fetal toxicity in some pregnant women with Ebola and Marburg virus disease and is being used to treat on a compassionate use basis pregnant patients with severe COVID-19. However, there are some reports that US FDA has now approved the use of remdesivir for treatment of COVID-19 infections. Two other drugs, hydroxychloroquine or chloroquine. Adverse maternal effects include abnormal heart rhythms, that is, the QT interval prolongation and ventricular tachycardia, especially in patients taking other drugs associated with QTC prolongation. Hydroxychloroquine does cross the placenta. Accumulation in fetal ocular tissue was seen in animal studies, and increased risk of fetal ocular abnormalities, however, has not been observed in humans. It is used in pregnant women for the treatment of SLE and for prevention of malaria. So it was previously also being used. Available data, however, are limited. A risk to the fetus cannot be ruled out when used at different doses, particularly the dose here which we use is more than 400 milligrams, equal to or more than 400 milligrams. A lot is said about the use of convalescent plasma, that is, the use of antibodies which have already been developed in some other person. Convalescent plasma has been used successfully in few pregnant women, sometimes for drug therapy like steroids, remdesivir, other antivirals, lopinavir, ritonavir, and azithromycin. When possible, it should be administered as a part of clinical trial that can assess safety and efficacy. Now, follow up. Follow up of women who recover from COVID 19. They are pregnant, their condition has improved, but what to do next? Development of FGR, fetal growth restriction, is a theoretical concern and it has been described in other SARS infection as well. However, the same remains, there is absence of robust data. Confirmed infection, if it is there, at least one ultrasound assessment of fetal growth and amniotic fluid volume at the beginning of third trimester and 14 days after symptom resolution should be done. First and early second trimester infection, for that a detailed fetal morphology scan is essential between 18 and 23 weeks. Timing of delivery in infected COVID patients. If this illness is not severe, non severe illness, and if preterm, and there are no medical or obstetric indications for prompt delivery, delivery is not indicated and ideally can be done sometime after a negative test result or after isolation status is lifted. So they are cured of their symptoms, and then 14 days after that, you can consider for delivery. Minimizing the risk of postnatal transmission to the neonate. So this helps in that those with medical or obstetric complications, pre-labor rupture of membranes or preeclampsia, the timing of delivery is determined by the usual obstetric protocols. What about severe and critical infection? There are multiple issues to consider, and timing of delivery needs to be individualized. Whether the mother's respiratory disease will be improved by delivery, and the risk of postnatal transmission in delivery room when maternal symptoms are acute are both unclear. Maternal antibody production and passive transmission to newborn and immunity may not have had time to develop. Increased oxygen consumption and reduced functional residual capacity in pregnancy may facilitate maternal deterioration in patients with pneumonia. On the contrary, excessive uterine distension, as in third trimester, polyhydramnios or twins, may again compromise pulmonary function and may prevent improvement. So, hospitalized patient and pneumonia, but not intubated, we should consider for delivery if pregnancy is more than 32 to 34 weeks, only if the mother's status is worsening. Delivery is always a challenge in these severely ill or critical patients. Timing of delivery of hospitalized, pregnant, intubated, and critical patients. After 30 to 34 weeks, delivery, if stable, to avoid pregnancy related problems, but this again could exacerbate the medical maternal condition. Others consider delivery only for refractory hypoxic respiratory failure or worsening critical illness. Between a viability of 30 to 32 weeks, as long as the maternal condition remains stable or improving. Continuing maternal support with fetal monitoring is essential and it prevents maternal morbidity and mortality and possibly maternal morbidity from iatrogenic preterm birth. In some situations of refractory COVID 19 related respiratory failure, maternal ECMO may be necessary. So it is again a controversy whether to deliver or not. Deliver, if you deliver, it may cause problems, and if you do not deliver, and the respiratory function may become severe. So this is the critical step and a team decision, multidisciplinary team should be involved in this decision making for the benefit of the mother and the baby. Breastfeeding. Infants born are tested by RT-PCR at 24 hours of age. If the newborn's risk for acquiring from its mother is low, data suggests no difference in the risk of neonatal SARS-CoV-2 infection whether the neonate is cared for in a separate room or remains in the mother's room. So, breastfeeding is being promoted. Mothers should wear a mask and practice hand hygiene during contact and physical distancing of more than 6 feet any times after that. So while she's feeding, with precautions she can feed, and otherwise she needs to maintain a physical distance. The virus has been found in some samples of breast milk, but data are limited and risk of transmission to the infant from ingestion of breast milk is unclear. Droplet transmission to newborn could occur through close contact during feeding. Ideally, the infant is fed express milk by another caregiver until the mother has recovered or has been proved uninfected, provided that the other caregiver is healthy and follows hygiene precautions. So, this is the ideal situation, which almost is never possible in many women. In such cases, mothers should wear a mask and thoroughly clean their hands and breast before pumping. The pump parts, bottles, and artificial nipples should be cleaned as well. If mothers breastfeed the infant directly, similar personal hygienic precautions, however, should be taken. This is a chart given by WHO. As you can see clearly, mother is asymptomatic or displays few symptoms, then in that case, rooming in and direct breastfeeding. But if the mother has symptoms, separation and giving pumped milk is ideal. Let us look at the clinical course and some evidences surrounding it. In a prospective cohort study on 241 pregnant women with lab confirmed SARS-CoV-2 infection who gave birth in New York City hospital during the surge, 61% were asymptomatic at the time of admission, but 30% of these patients became symptomatic before discharge. Mild, severe, critical cases 27, 26, and 5% were seen during the delivery hospitalization. Severe disease appears to be more prevalent in the late versus early pregnancy, particularly among pregnant women with comorbid conditions that increase their risk. Pregnancy complications. Preterm birth and cesarean delivery rates have been increased in many studies, but not all. Fever and hypoxemia may increase the risk of preterm labor, trauma, and abnormal fetal heartbeat patterns. Preterm deliveries occur in patients with severe respiratory disease. Many of the third trimester cases are electively delivered by cesarean section because of bias to intervene catalyzed by the belief that management of severe maternal respiratory disease would be improved by delivery. However, this hypothesis is unproven. The frequency of spontaneous abortion does not appear to be increased. However, 95% of newborns have been born in good condition at birth. Many neonatal complications related to preterm birth to adverse uterine environments resulting from critical maternal disease. Hypothermia in COVID-19 is a theoretical concern. The febrile illness is said to cause problems in organogenesis in the first trimester, and the risk of congenital anomalies, especially NTDs and miscarriage. However, increased incidence of these outcomes has not been observed. Acetaminophen is safe, may help attenuate signs and symptoms of hypothyroidism, which occur due to infection. Now, this is a flowchart given by Foxy for management of pregnant women with suspected or confirmed COVID infection and respiratory symptoms. So, as soon as she comes, give her a mask, reassure her, and the healthcare team, donned in PPE kit, should examine her. You should find out whether there's an obstetric emergency and whether she's in labor or not. If she's not in labor, then plan whether admission is needed or not. If she is stable or not, if she's unstable, again, she needs hospitalization. Move her to a designated area, which includes a labor delivery complex and OT and ICU wards, and transfer should be allocated for these patients. Inform COVID team and It is the multidisciplinary team which should look after this woman. She should be monitored by early warning sign system, the SOFA score. Her worsening condition should be identified, sepsis pathway. In the end, you should decide whether she requires labor management or surgical intervention. For management of labor, she is kept in a delivery suite and minimize the number of persons in that room. Healthcare team should be in protective gear. Birth companion can be allowed. Routine monitoring protocol for high-risk pregnancy, hourly vitals, intake, output charting, fetal monitoring as per protocol, minimize interventions, Antonox, that is nitrous oxide gas, use only with single filter, or many societies have recommended not to use. Water birth is contraindicated. Cut short the second stage if she is getting exhausted. Mode of delivery, CS is reserved only for those with obstetric indications. Delayed cord clamping is recommended, and vertical transmission has not yet been proven. If she requires a surgical procedure, and she should be shifted to the designated OT for COVID, minimize movement in the OT premises, minimize the number of people responsible in the OT, anesthesia, regional anesthesia is preferred, antibiotic prophylaxis is recommended, post-op care as per standards in an isolated room with barrier nursing and universal precautions. So, just to highlight a few important points which should be considered. SARS-CoV has not been detected in vaginal secretions or amniotic fluid. So, rupture of fetal membranes and intrafetal heartbeat monitoring may be performed for usual indications. COVID-19 is not an indication to alter the route of delivery. Generally, management of labor as such is not altered and it depends on the obstetric indications. Partner or support person should be screened if positive or within 14 days should not be allowed to attend labor. Neuraxial anesthetic, that is spinal subarachnoid block, is not contraindicated and has several advantages in laboring patients. Society of Obstetric Anesthesia and Perinatology have suspended the use of Antonox. Avoid delayed cord clamping in term infants. Benefits are modest, but it minimizes newborn exposure to virus and environment and reduces the chances of jaundice. NSAIDs for treatment of fever and pain. Although negative anecdotal reports are there, acetaminophen is the preferred antipyretic and analgesic agent. NSAIDs, if at all are needed, the lowest effective dose should be used. So that all details were about pregnancy, management, and labor. To summarize what all I have mentioned with a few highlights, same recommendations as non-pregnant for avoiding exposure. Clinical manifestations may be similar to non-pregnant and there is less fever and myalgia in pregnancy. Testing all patients upon or before admission is reasonable. Pregnancy does not appear to increase susceptibility to infection. Most infected mothers recover without undergoing delivery. Pregnant women may be at an increased risk for severe disease necessitating ICU admission and ECMO. Risk factors for severe disease include age more than 35 years, obesity, hypertension, diabetes. Maternal deaths have been reported, but not in excess of those in non-pregnant and reproductive age. Infected women who develop pneumonia have increased chances of preterm birth and cesarean section. Few early newborn infections and placental infections have been reported. It is possible, but there is an uncommon vertical transmission. Because what postnatal contamination could not be excluded conclusively in all those reports. The use of dexamethasone, both for maternal treatment as well as for enhancing young maturity, can be given 4 doses, 6 milligram IV, 12 hourly to induce fetal maturation, and this dose it can be continued to complete the course of COVID-19 infection in a dose of 6 milligram orally or IV for 10 days till discharge. Preterm COVID-19 and non-severe illness who have no medical obstetric indications for prompt delivery. Delivery is not indicated and ideally to occur sometime after negative testing or completion of isolation studies. Severely ill patients at least 32 to 34 weeks of gestation with COVID pneumonia and with severe disease may at times benefit from early delivery. These were the references from which I've taken my text. So to conclude, pregnant women may be at increased risk for severe illness from COVID-19. Women, pregnant ones, and their families should take steps to stay healthy and reduce their risk for getting this infection. If you have any questions, feel free to contact me. Do subscribe to my channel